The linvoseltamab is a bispecific, CD3, targeting CD3 on the immune system cells, the T cells, and targeting BCMA on the tumoral cells. Right now, linvoseltamab is IV. You start 4 hours, you drop to 2 hours, you finish at 30 minutes. So it's not inconvenient in the outpatient clinic, although the company is trying to look into a sub-Q formulation route, which would improve even more. With linvoseltamab and other bispecific is that if you have a very serious prevention of the infection, that you could not entirely, but very 90+% manage the infection and make it not a problem. You cannot 100% of the time get rid of it, but it's getting really good. And then for the rest of the potential side effects, of course, many patients are profoundly lymphopenic, but if you drop dexamethasone very early on because you don't need it, it's just a pre-medication initially for the CRS, and if you give Bactrim and valacyclovir, you have patients with grade 4 lymphopenia, but they do not have infection. You have neutropenia from time to time, but again, this neutropenia is limited, is mild, and recovers. And then in the non-hematological kind of spectrum of side effects, sometimes you have diarrhea, sometimes you have rash, particularly the palmo-plantar, the feet and the hands, the palm of the feet and the palm of the hands, that could have a rash. But again, over time, it gets away, and if you go monthly, it gets away. So it's really not a problem. So the non-hematological side effects with linvoseltamab particularly, but the bispecific BCMA in general, beside infection, are really have never been much of a problem. The future of linvoseltamab is very interesting because if we have patients that cannot tolerate bispecific plus CD3 monoclonal antibody, but we have another option. We could go single agent or we could go for a different combination. It's very important for the patient to have a plan B and a plan C because you always offer the patient the best treatment initially, but you never can anticipate the safety profile. And for many patients, the safety profile is difficult. Sometimes it has nothing to do with the drug. I have many patients, it's not truly the drugs, they just come with, they are 70 years old, they are not 2 years old, so they come with history of comorbidities, history of prior medical issues, etc. And when you give the drug, it's sometimes difficult. What I like with linvoseltamab is that the way they have developed, and potentially because they were coming late, will offer different options to the patients. And in the end, as a physician, it gives me more options to adapt to the patients. You know, we keep talking about tailored therapy. If you want to have tailored therapy, but if you have different options, it's easier. Because then you can say, for you, it's better this, for you, it's better that. So I think the linvoseltamab development will offer that to the patients, their families, and for us, the physicians.